The ambulatory surgery centers are required to be in compliance with the federal requirements set forth in the Medicare conditions of coverage. And there's 138 pages of those coverages. Survey protocols and interpretive guidelines are established to provide guidance to personnel conducting the surveys. Whether you have an accreditation survey conducted by CMS, AAAHC, or the Joint Commission, the basic guidelines are established by CMS. These surveys are an open book test. You will get written document requirements from either of the accreditation agencies at the time of your application. CMS conditions of coverage are defined in their guide for surveyors, and the website below gives you access to the CMS Ambulatory Surgery Center guidelines that if CMS comes in, it gives you exactly what they're going to do when they're there. Our goal today is to review some of the high deficiency standards which were less than substantially compliant during the survey year of 2020, 10% or more of the time. The most common accreditation deficiencies fall in the chapters of credentialing, privileging, and peer review, documentation, quality improvement, infection prevention, and safe injection practices, and emergency preparedness. The purpose of the standard for the credentialing process is to confirm that during the appointment and reappointment processes, the governing body ensures healthcare professionals are qualified to provide services offered by the organization, and those services are appropriately staffed and supervised. This ensures the reappointment term meets the state guidelines of at least 3 years. It can be less than that depending on your state guidelines, which many of them are 2 years, but if it is 3 years, you can go to 3 years. Reappointment process must include updated information, attestation with signatures, and peer review. The credentialing, privileging, and peer review are 3 separate but related processes. Credentialing is validating an individual's personal qualifications to provide healthcare services. Privileging is the formal process of obtaining governing body approval for a provider to deliver specific treatments, procedures, or to use specific equipment. And peer review is confirming a provider's competence by enlisting other or similar licenses or other privileges to review clinical records and other aspects of care. Deficiencies identified for credentialing: in the initial appointment, credentialing files are missing or contain expired board certification, missing peer reference letters for initial appointment. When your bylaws state that you require 3, then 3 should be in the file. Policy and practice should be consistent. Signed application and attestation is very often misdated. In reappointment, the appointment policy and the reapplication form specific for reappointment for both providers and allied health providers. Don't use the same form for both. The deficiencies that are noted are: the process consists of completing a disclosure question form, privilege list, and authorization form needs to be consistent with signature and date. When I'm looking at these deficiencies, the reason they're not in full sentences is because this is the way they were identified in the deficiencies in the standards. You have missing reappointment application and supporting documentation. You have credentialing policy does not address the requirement for attestation questions. Your signed application was misdated. Files were missing attestation questions, i.e. the release of liability signatures, missing or expired board certification, missing reapplication process or form, that there's no written reappointment policy. CRNAs did not complete a reappointment application, missing peer reference letters for initial appointment, and resident physicians are not credentialed. Privilege and peer review process. Privileging always makes sure that the scope of services approved for the center and the delineation of privileges match. Only approve those procedures appropriate to be performed in an ambulatory surgery center. Do not approve a provider a privilege he should not be performing in your center. Deficiencies identified are privileges are outside the scope of education and training. Privileges are requested but have no proof of approval by the governing board. The length of privileges granted misalign with the appointment period. Privileges for anesthesiologists do not contain the supervision of CRNAs as required by regulations in some states, or requests for the use of ultrasound. On reappointment deficiencies, there is no request for privileges. The privileges are not requested within the reappointment time frame. Remember that your reappointment time frame is similar to your license, and if you're outside of the time frame, you're outside of your license is closed. Peer review. The center's peer review process needs to be defined with inclusion of criteria defined by the governing board with proof that physicians have participated in the criteria selection. Peer review is used to define internal benchmarking, and information needs to include more than chart audit. There should be a physician report card with specific criteria noted, i.e. transfers, infections, patient complaints, return to the OR, etc. Deficiencies noted are lack of documentation regarding data collected to evaluate important aspects of care. Credential files does not reflect the review of peer review for criteria for reappointment, and consistent monitoring of critical aspects of care were not documented. Privileging deficiencies are identified and approved by a privilege with no explanation or description. Privileges for anesthesiologists do not contain supervision or CRNAs as required by regulations and the use of ultrasound during regional nerve block. Approved privilege sheets do not contain a specific period of time. Providers did not request privileges during reappointment process. No documentation privileges were approved by the governing body. The CRNAs are privileged to provide regional and general anesthesia, but there is no delineation of the 3 levels of sedation, including minimal, moderate, or deep. They are privileged to provide intravenous sedation. Privileges granted were outside the scope of procedure. Privileges granted were outside of education and training. Allied health or contracted providers were not granted privileges according to the process. Length of privileges granted misaligned with the appointment period. Peer review deficiencies. Peer review information was not used by the governing body for approval for credentialing or reappointment. No evidence that peer review was used to develop internal benchmarks. No evidence peer review is one of the criteria for credentialing. No credential trends or peer review discussed or reviewed at the time of reappointment. Peer review was not conducted and data collected only identified issues with clinical records such as missing signature or incomplete form. You have a lack of documentation regarding data collected to evaluate important aspects of care. There's no documentation that the organization tracks their peer review trends. Peer review was a part of initial process, but no reappointment process is identified. Peer review results are summarized. Credentialing files do not include any statement that peer review was considered, even though peer reviews are maintained in a binder. Data collected is related to clinical record content, completeness rather than providers' quality of care accessed through peer review. And there's no peer review process for monitoring clinical incidents. Example, infection rates, complication rates, or quality data collection in general. Documentation, the purpose of documentation is related to the standards is to ensure that patient safety and quality of care, especially as it relates to continuity of care, medication reconciliation, and patient allergies, are defined in your medication reconciliation, your allergy documentation, and your clinical records for clear, complete documentation. Medical reconciliation deficiencies. Medical reconciliation is not performed or is performed sporadically. There's not a consistent policy that defines the process. There's inconsistencies with no newly prescribed medication list, no discontinuation of medications recorded, included in patient instructions. There's no resumption of medications in patient instructions or on the reconciliation form. And this is specific to anticoagulants, but all medications should have a resumption documentation time. Medication reconciliation doesn't include over-the-counter or herbal supplements. There's no discharge instructions regarding the dose, the strength, and the frequency of discharge medications. There's no form provided to patient upon discharge, and there's no documentation or documentation was inconsistent with patient discharge instructions. Allergy documentation. The allergies are documented, but there's no specific reaction information recorded. Allergies, sensitivities, and reactions are not updated at every visit. There's an inconsistent use of known drug allergies versus no known allergies. And you should always just have your known allergies. Your form designated for allergies isn't consistently used for every visit. Your allergies, sensitivities, and reactions are not noted in a prominent defined location. And there's inconsistent allergic reaction documentation, i.e. in your nurse's notes and anesthesia records, which don't match. Your quality improvement deficiencies, the intent of the standard is that this standard is to ensure organizations have a quality improvement program that includes ongoing data collection, analysis of trends, examination of performance versus external peers, which is external benchmarking. There's no process or policy on conducting external benchmarking. There's limited documentation on quality monitoring. There's no evidence of data collection and quality improvement. There's no ongoing comparison of peer review results to internal or external benchmarking. Excessive or sole reliance on your quality activity. The purpose of the statement did not include why the problem was significant to the organization. Studies incorrectly documented data after corrected action as the initial data. No documentation that the results of the study were shared with the governing body or the staff. There's unclear goals, and remember that your goals should be numerical. Your comparative data to what your goals should be and why you're doing the study. There's inadequate data analysis goals. There's no clearly identified corrective actions with either measurement or remeasurement. Additional corrective action were required since targeted benchmark goal was not achieved, and the remeasurement after the corrective action differed from the initial measurement. Clinical record deficiencies include COVID-19 lab results are not authenticated or dated. The history and physical stated none. However, patient had a detailed medication list completed at pre-op. Current medications and dosages not consistently included in your clinical record. Your history and physical over 3 months old, but there was no documented update in the chart. The history and physical signed by the provider, but there's not a time or a date stamped. Labs, EKGs, etc., are not consistently signed off by the ordering physician or a qualified designee. The history and physical did not include a complete review of symptoms or not relevant to the procedure. The transfer record reviewed contained EKG done at the facility, but no documentation that it was reviewed by the anesthesiologist. There's no documentation of the ER transfer follow-up, and the results of referrals are not in the clinical record. Infection prevention. Your intent of the standard is the purpose of these standards is to ensure organizations reduce the risk of infections by developing and regularly reviewing infection control and prevention program. Having a designated person as a coordinator educated to oversee the program. The deficiencies noted is there's no evidence of the infection prevention control designee appointed, training, or competency. The documentation of education and training in infection control was not evidenced. The infection prevention control designee is not up to date. The governing body has not indicated the specific training and current competencies required to direct the program. The infection prevention control is not trained in cleaning, sterilization, or surgical instruments. There's no documentation or of endoscopes reprocessed and by whom. The guidelines on the immediate use is not being followed. No written policies addressing the identification and processing of medical equipment and instruments that failed to meet sterilization parameters. A perforated sterilization instrumentation was stored and dated ready for use. The certified surgical tech responsible for sterilization was unable to describe use of the spore testing for autoclave sterilization function monitoring and indicated this is not used. Stethoscopes were not cleaned before and after use on a patient. Linen was found uncovered in a patient care area. Insufficient or no monitoring and documentation of cleaning, high-level disinfection and sterilization, failure to follow the national guidelines and manufacturer's instructions for use. There's not following the CDC, APIC, or other requirements adopted as policy for hand hygiene and safe injection practices. There's no safe injection practice or hand hygiene training or surveillance program. With safe injection practices, the standard is to ensure safe injection practices follow a CDC AORN program for safe injection practices and a program to prevent medication errors. The deficiencies noted were not treating a multi-dose medication opened and drawn in a patient treatment area as a single dose vial, opening, dating, and saving multi-dose vials on anesthesia carts, OR, and PACU for future use as opposed to keeping the multi-dose vial in a designated clean area away from patient care or trending multi-dose vials as single-dose vials because it has been in an unclean patient care area. Syringes were labeled but not disposed of in the sharps container. Open and undated vials of insulin in the refrigerator in a patient treatment area. IV hub not sterilized each time by anesthesia administered. Not sterilizing your medication vial stopper before drawing medication. Not labeling medication drawn up prior to the procedure. Not immediately using a pre-drawn medication. The anesthesia cart and the computer keyboard was not cleaned between patients. Syringe was recapped with 2 hands, which could result in a needle stick. Not following organization policy on handling and disposing of expired materials. And the disposal policy for narcotics directed staff to flush the medications. Safe injection practices, drug recall policy does not address how staff determine if recalled items are present or how, if patients are notified, the medication was used in their treatment plan. Staff unable to identify an example of a recall or recall log. The policy does not include a process for patient notification. The expired medications and other items found in cabinets, on anesthesia carts, emergency carts, or in the refrigerator. The list of confused drug names, medications did not include the many eye drops present at the facility. There was no list of confused drug names at the facility or not specific to the drugs on their formulary. The high alert medication list is incomplete, and marking of medications with red stickers does not align with the medication list. A list of confused drug name medications exists. However, individual medications not labeled for ease of identification per list policy. Emergency preparedness. The extent of this standard is the purpose of this standard is to ensure the organization is prepared for all types of emergencies, CPR, fire, active shooter, natural disasters, following the CMS guidelines for preparation and completing a hazard vulnerability assessment to identify risk, severity, and probability. The deficiencies identified as 4 drills were conducted, but not quarterly and not scenario-based. No fire drills were documented. No documentation that the required number of drills were conducted. There was no disaster and emergency drills conducted. CPR drills were not conducted or not scenario-based. Drills are not regularly evaluated, or evals were very short or missing. There was no follow-up on deficiencies noted during the drill. The CPR and the MH drills are in services and not evaluated in a drill format. No exit signs over the designated fire door exit. Exit sign not illuminated. 2 exits are not noted to be an exit. Missing directional chevron on exit signs. No visible exit sign in the central restricted OR. Exit sign was pointing in the wrong direction. Batteries in the exit sign are not tested. There's no visible exit sign in the center's clinical corridor. And the exit door that leads into the core is not equipped with a push bar. And exit signs are missing in hallways. Drill suggestions versus mandatory and required. Many times there's confusion in regards to what's mandatory and what the frequencies are. Your mandatory drills is there is a requirement for a fire drill to be performed quarterly, and you need to pull the alarm. The CPR is annually. Your malignant hyperthermia is annually. Your disaster emergency preparedness drill is annually, and a tabletop with the community. Your drill considerations, which include additional emergency that you identified in your hazard vulnerability assessment, active shooter, emergency blood drill, bloodborne pathogens, a pediatric drill, and an incapacitated physician are some of those that could be considered to do on a periodic basis. All drills are required to be scenario-based with evaluation and corrective action implementation documented.
Okay, thank you so much for all of that information, Marie. So now we're going to open it up to you guys. If you have questions, please type them up in the chat box on this webinar, and I will read out those questions one at a time to Marie so that she is able to answer. So whatever questions you have for Marie, who is a surveyor, whatever that question may be, just please go ahead and type it in the chat box, and I will ask Marie the questions. Presentation. Casper is asking to please provide the presentation slides. So which we're going to.
I think you already said that you would do that.
Yeah, so he might have missed out. So we are going to email out this slideshow PowerPoint presentation, as well as a recorded, this whole thing has been recorded. So we're going to get that sent out as well too. Do you have to pull the fire alarm at every drill, or can they be smoke drills?
The requirement is that you have a fire drill, and even with a smoke drill, you don't know if it is a fire that's causing it. The requirement is that you notify your alarm company and let them know that you're that you're going to do a drill. You don't tell your staff you're doing a drill. You tell your alarm company, you pull the alarm to see whether how the staff respond, and you time their response.
Fire drills template in A is up to date with what Surveyor. Oh, this person's asking me, are the fire drill templates inaccurate, up to date with what surveyors are looking for? That's Teresa. So Teresa, I will pass on our template, our fire drill template. I will pass that on to Marie after our webinar, and just make for sure on that. You know, I'm sure it is, but I will have her double check that. What do they mean by COVID test being authenticated, Marie?
Well, any lab that you order in for the patient should be authenticated and identified that it's been reviewed. And so what many surveyors are looking for is that there's an initial on the result that states that it was authenticated and reviewed so that the tests were done for no reason. And that's true with any point of, or any test that you require. The anesthesiologist or the physician should at least acknowledge on the result that they've looked at it.
We have another question here from Melissa. For a new center in California, after early survey and before initial survey, can the 10 cases be general anesthesia?
Yes.
So Melissa, the answer to your question is yes. And then Teresa also says, Teresa Lewis says, what is the minimum standard for endoscope drying?
The minimum standard?
The minimum standard for endoscope drying.
Oh, in other words, how long does it have to dry before you can reuse it?
I think that's what she's asking.
I would have to look that up and I'll get that answer to you. I don't know the answer to it right now.
Teresa, we will get back to you on that one. So the next question is Melanie. Do all emergency lights have to have a battery backup or just areas not covered by the emergency generator?
It's expected that all emergency lights have a battery backup so that in case of an emergency and the power goes out, the direction for being able to see where you're going is there.
Trisha says, is there a form that has all the required drills that we must do and the time frame they are required to do them?
Yes, there is, and I will get it to Marissa and she will get it out to you.
All right, I'm just writing all this down, guys. Okay, so the next question, is there a mandatory time frame for results of specimens to be returned to ASC? And is it mandatory for the patient to be aware of the results?
The surgery center sends the specimen. The surgery center is responsible for the results, and the surgery center is responsible that the physician gets the results. The physician's responsible for making sure that the patient gets the results. As for a time frame for the results to come back to you, it should not be more than, I would not think should be more than 7 days, but your pathology lab should give you that guideline so that you know what it is and you're reviewing it within that time frame.
Okay, Melissa, if you will send me over an email, this is Marissa, Accurate Accreditation. If you will send me over an email and we will talk to Marie about getting that in writing. So our next question is Lynn Zeller. Are there any guidelines for the testing of patients for COVID prior to surgery?
No, that's a CMS or that's CDC guideline. Many surgery centers have quit testing prior to. It is a decision that you should make. As a matter of fact, I want to make sure that everybody has reviewed that new COVID-19 healthcare staff vaccination worksheet, because if you're having a Medicare survey, the first question they're going to ask is your vaccination requirements for your staff. But you need to go online for your state for the requirement for whether you need to test or not. All I do is ask the center what their policy is and whether the governing board has made a decision on it. And if they're not testing because that's the decision they made, then their policy has to follow their practice, or their practice has to follow their policy.
Okay, so the next question, COVID-19 vaccine records, are they still mandatory given the changes with government?
Check with your state, but CMS just came out with a guideline that you have to have your staff 100% vaccinated, whether they're vaccinated, whether they have got a exemption, whether it's religious or medical, and there's a time frame and the state. So if you go on the CDC guideline, or go on the CDC website, there is the colors for when that requirement has to be. Phase 1 has to be 80% compliant by February 22nd. Phase 2 has to be 90% compliant by March 21st. And the enforcement of it is by April 20th. So everybody should have gotten, if you're AAAHC, they did a webinar in regards to what the surveyor is going to ask when they come into your center. But CDC did a webinar in regards to the requirements for ambulatory surgery centers as well for their staff.
Okay, so Billy Aycock has a question. Is evidence of IP training sufficient, or must there be an IP competency? What would demonstrate sufficient IP training? What components would be required in an appropriate IP competency?
The requirement is just, there's not a competency that I'm aware of, but you just have to have documented evidence of the IP person completing infection control prevention guidelines for an ambulatory surgery center. And there's a lot of online as well, but I will check to see if there's a competency, and if there is, I will get it to Marissa.
So Bill, if you will, send me over an email, just kind of following up on that, so I can make sure to get that data from Marie, if there's more for her to give you there. So if you will, shoot me over an email. Again, this is Marissa at Accurate Accreditation. If you guys want to jot down my email, if you don't have it, it's MMIELKE@accurate.com. So the next question, Rosanna, are there some simple resources on environmental services requirements and facility requirements?
AORN has a very good facility program for the people that's cleaning your environment. I will look and see what else is out there for you.
Okay. So Rosanna, sorry if I'm mispronouncing that. If you will, please shoot me over an email as well to follow up on that. So then we have Jay Vasquez, I think that's Jennifer. Is it mandatory for staff to have a training that consists of them actually using fire extinguisher?
Yes. They should never pull it, but you have to do that race past the fire extinguisher guideline for. Now, the silly thing about it is your fire department's going to tell you not to ever use your own fire extinguisher and get out of the building, but many of your fire departments that are close by your centers will come and do that training for you if you call them and ask them. Okay. And you only need to do that once a year.
Okay, so the next question, Marianne. On the initial survey, do I need a 4-hour load test? I'm told the initial startup for 2.5 hours is sufficient for DOH Article 28, and then do a 4-hour load test after 36 months.
Your 4-hour load test is on an annual basis, as far as I know, and because you're just opening, you have to complete the required testing for initial generator and for your monthlies, depending on when you got your certificate of occupancy and how long it's taken you to get your license and for the accreditation agency to come in. But your 4-hour load test is on an annual basis. So I do not, but I will ask the life safety person that I work with frequently. And if I am wrong, I'll get that to Marissa.
Marianne, if you will, shoot me over an email as well. As you can see, we have tons of questions on here. So I want to make sure I do follow up with everybody. So If you've asked a question and Marie has said that she could potentially get you additional information, please shoot me over an email. So next question, Leticia is asking for guidance. She says, our exit lights are connected to the generator, so no batteries. What would be the best way to test document?
There is a way with your exit light company. They'll tell you how you can do that. There should be, there's always a way to test them to see if they're working when the power is out.
And the next question, Tricia asked, is there required training a staff must do for medical gas? We have a company that comes out to change the tanks, but I was under the assumption that our staff has to have official training. I have looked everywhere and this is not easy to find.
I've always told my staff to leave the medical gas alone. It's not theirs to touch. So I do not believe that I've never asked for education and competency on medical gas, but I will look for that requirement. And if there is one, I'll get back with you.
And Tricia, also, if you will, please send me over an email. I can check with our medical physics training and see if they have some sort of education bit on that as well. Let's see. So the next question, if a suture was not accounted for and radiographic images were performed to confirm it did not stay within the wounds, does the physician need to document that in the operative report? Does the patient need to be made aware, and should an incident report be completed?
An incident should be report should be completed because you want to make sure that you don't have that occur frequently. That's a, you know, and you still have to, you don't have to tell the patient, and you don't have, the doctor should document it. He has to decide how he's going to document it, but you do have to do an incident report because you don't know what happened to it, but it does not appear in the patient, so you can go on with closure and that stuff because you're not going to open them up to look for it. But at some point in time, you need to pull all of your garbage and everything apart to figure out what happened to it, because it didn't just disappear.
So the next question from Casper says, isn't the CMS ruling effective 11/29/2019 that the center must participate in a community-based full-scale exercise every 2 years, not every year? I believe this ruling also includes that if the center experiences an actual natural or man-made emergency that requires activation of the emergency plan, the center may opt out from engaging in its next required community-based or individual facility-based functional exercise following the onset of the actual event.
That's correct. CMS did come up with a revision of their guidelines for their disaster emergency preparedness. And you can pull that off of the CMS website for emergency preparedness planning.
So the next question, Lynn Zeller says, if there are 2 surgeons performing separate procedures, does each surgeon have to complete their own H&P?
No, because they're doing, so in other words, it's like plastic surgery where one finishes a case and then the other physician comes in and starts a new case for implant or whatever. So he has to document that he's evaluated the risk of the patient for appropriateness of the procedure, but he doesn't have to complete a full H&P. But he does have to document that he's evaluated and talked with the patient in regards to what he's doing for that patient.
Okay, so our next question is from Kathleen. What are the vendor rep credentialing requirements?
You have to know that they have completed HIPAA, that they've completed their immunizations that are required by anybody else that is in a room with a patient. And you have to know that they are truly with the company that they say they're with. So you have to track that information. So RepTrack or one of those is an easier way of doing it. But if you choose to do it yourself, then you have to get that information from the company. And you
Okay.
have to provide an orientation to the center.
Okay, our next question is from Bill. He says, extension of training question. What is considered appropriate and sufficient training in cleaning, sterilization, or surgical instruments?
They need to complete a competency that they understand the process for your policy of what you follow for manufacturer's guidelines for the cleaning, the rinsing, the wrapping, the sterilization according to standard. Steris University has great free webinars on their website in regards to all of that. But your policy and your job description should define the requirement for your competency for those personnel. If you're choosing to hire somebody that is not certified and has not gone through an educational component, then you have to have a process for educating them appropriately to be able to comply with those standards.
So next I have here, Cheryl and Trisha both have said our medical gas company now states they cannot hook the gases up anymore.
Why not?
Cheryl and Trisha, can you?
Well, they have to identify from the company why they made that decision. And then if they have chosen to not perform that service for you, then you have to have them educate staff members that are going to be responsible for doing that in an appropriate manner.
Okay, and that's what happened. And, you know, now that I'm hearing it being discussed, I will ask them for that in writing. But the guy did in service a couple
Right, but
of,
it makes no sense to me why they've decided that they can't do that.
he said that
Was
they
there,
would be,
did they
they
have
would-
an incident someplace that caused them a liability, so they chose to not do it for every place?
I think so, because he said that they would be liable for, you know, not opening it or hooking it up wrong or whatever. And so, but I will ask for that in writing so that we can kind of close the loop on that understanding. Thank you.
Yes.
Okay, so the next question I have here is there a complete list of education and competencies recommended or required for surveys, or a complete comprehensive list in general for an ASC for all departments within the surgery center?
So you're asking the education for each position?
Yep, she says, is there a complete list of education and competencies recommended or required for surveys, or a complete comprehensive list in general for an ASC for all departments within the surgery center?
Oh, there's a list of the mandatory required, and then there's a list of the position specific. And the position specific, it depends upon the cases that you're doing in your center so that your staff are knowledgeable for what they need to do to support the standards that you're stating you're performing in your center. I can give you a list of all of the educational components that should be reviewed, but your competencies for what your position tasks are is specific to your center, and you can pull them off of either AORN or one of those standard guidelines. AAAHC, and when I've been with JACO, I don't believe that they have a list of competencies that have to be identified. That's ASC specific for the positions that you choose to have in your center. But I'll look into that and see if there's something that I can get for you.
So Amy, if you will, shoot me over an email so we can make sure we follow up on that. Our next question is from Michelle. In regards to the above question, I would love that information as well. Okay, perfect, Michelle. Just shoot me over an email too, please, just letting me know so we can get that to you. Leticia has another question in regards to hospital transfer agreements. We used to get a letter from a hospital documenting a transfer agreement every 2 years. In 2021, they did not respond with a letter. I want to verify that my notification letter sent to the hospital administration is enough documentation. Do I need to do something else?
Your letter to the hospital should be enough. One of the things that I just noted is that they're going to do for HHC, and I don't know for JACO, but they're going to have an open forum because they're looking at the standard right now for transfers to the hospital, because CMS changed their guidelines for the requirement for a transfer agreement versus the physician having privileges at the hospital. And so pull up those guidelines from CMS in regards to the requirement for a transfer agreement versus admitting privileges. Most hospitals, there are some hospitals that I have heard are not even approving transfer agreements because the patient can come to the emergency room and they can't turn them away anyway. So I'll look at that guideline, but I know that they're looking at it with HHC right now in regards to the requirement.
Okay, so our next question, clarification of appropriate and sufficient training in cleaning, sterilization of surgical instruments. Question, this was the slide for IP training. What is the level that the IP needs?
They have to have at least 6 hours of infection prevention for a as an ambulatory surgery in an ambulatory surgery center. And like I said, there are a lot of different education components out there. And they should have knowledge of the sterilization process that's going on within their center. They should have knowledge in regards to their infection prevention program itself, and in regards to the requirements for safe injection practices and for good hand hygiene overall. So it should be an overall at least 6 hour infection prevention coordinators ambulatory surgery center program.
Okay, Melanie Russell has another question. She says, is an oxygen monitor is an oxygen monitor or detector required in the med gas room?
I do not believe that there is, but I would have to look at that question because I've never had that as a requirement that we looked at.
So Melanie, if you will, shoot me over an email and we will follow up with Marie on that. So that looks like the last question I have. Do you guys have any other questions? We have about 3 or 4 more minutes. So if you guys have questions for Marie, please put those in the chat box. We have just a couple more minutes on here. If you did have a question today, please remember to send me an email so that we can follow up with Marie on that question. Does an RN have to review lab results?
Your policy needs to state who in the center receives the result and make sure it's within parameter. The doctor's response, it doesn't have to be an RN, but if it's outside a parameter, at least an RN or a physician should look at it the day that it's received. A lot of times the results come into the medical record department and they just ensure that it's there, but somebody should look at it for appropriateness of whether it's normal or abnormal, because then your policy states how quickly you address an abnormal response.
Leticia wants to know, she's new to Accurate. She wants to know if we can do these on a regular basis. Marie, correct me if I'm wrong, but I think we do have talks about doing more of these surveyor webinars. Is that right?
Yes.
Okay, perfect.
I think we're talking quarterly, but I'm not sure.
Quarterly, yeah, I think so too. I think that's what Lisa said. Rebecca has a quick question. Clarification of the needle versus syringes in the sharps box. I thought empty syringes did not have to be in sharps container, only needles.
And I agree with that. I don't know the stance that the deficiency that was noted in that was a deficiency that came from the home office of all of the deficiencies that were noted over the 2020 year. And I do not, if they take the needles off, I think that, the syringes usually go into a big red box, but if you have a defined process of how you do it, you just need to make sure that they're secured.
Next question, Kathleen, what documentation is required to prove lab services are available?
Do you have a pathology service that like LabCorp or Quest or the hospital? And what you do is you talk to them. If I need emergency labs, do I draw them and send them to you? And do you have a process in place, or do they send a courier? So your policy just has to define for Medicare how you would respond for emergency labs if you needed to secure them. That's why I said that if you're a center that does large cases that may need to use blood, if your policy states that you don't keep blood or blood products in your center, you should have a process in place with the lab that you can get O negative blood in an emergency if you needed it. All they're asking is that you've thought through the process and you've identified how you would accomplish it if it was the ultimate that I needed it.
We have another question real quick. Michelle Brewer, this is extremely helpful. So glad we are now with Accurate Accreditation. Thank you both. Could you provide your email address again, Marissa? Yes, my email is mmIelke, the number, at accurateaccred.com. I'm going to put it here in the chat for you guys. Okay, I just put my email in the chat for you guys. So Michelle, look forward to hearing from you. Marcia, new DON, previous DON left with 1 week's notice, struggling with quality improvement versus benchmarking. Any advice, Murray?
Yes. Follow your external benchmarking has to be with has Accurate started external benchmarking yet for all of your centers? Or you can have ASCA, or you can have the Ohio, if you're in Ohio, the OASC, or you can do the California. But you have to externally benchmark with some, and then some of the monitoring that you're doing is reviewed by your quality, but don't make your quality studies difficult. I'm more than happy to take 5 minutes and sit down and talk with her one day just about quality if she wants to, if you want to give her my phone number or my email address.
Okay, perfect. So I think it's Marcia. I think I'm saying that right. Marcia. If you will shoot me over an email, I will get you in contact with Marie. Sounds like she's more than happy to help you out with some advice there. Appreciate all the information. You're welcome, Kathy. Perfect, Marcia. Sounds good. Okay, guys, so that's it. We've reached our little 1 hour mark here. We want to thank everybody so much for being a part of this and joining our webinar. It does sound like we will be holding these quarterly. More information will be sent out as we get that arranged and set up. If you guys have questions, if you need anything, please don't hesitate to reach out. I'm Marissa, the customer service manager here at Accurate Accreditation. If there's anything you think of that you want to ask Marie, please shoot me an email, let me know. I will definitely pass that on to her. So thank you guys so much. Marie, do you have anything else?
Nope, I appreciate them taking the time out of their day because I know that they're very busy. And I respect every one of you in your positions because it's not an easy job. God bless and have a good week.
Thank you guys so much. Everybody take care. Thank you so much. We will talk to you all soon. Thank you, Lila.
Thank you.
Bye, bye, Marie. Thank you so much.
Thank you for all your hard work. I'll
You're
talk to you
so
soon.
welcome. Thank you, Marie.
Bye-bye.
Bye-bye.